Hello everyone, how's it going? Today you are going to study a new chapter, Diuretics. What are the diuretics? Maybe you are asking. Actually, they are the drugs acting on the kidneys to promote urine production and excretion. And urine is the main way for water and electrolyte and metabolized substance in the body to excrete. They are used to adjust the volume and composition of body fluids in a variety of clinical situations, including hypertension, heart failure, renal failure, nephrotic syndrome, cirrhosis, hypercalcemia, and kidney stone, etc. Before you study the diuretics, you had better to review the renal urinary physiology in order to study the mechanism of diuretics. Although this is the review of physiological knowledge for you, but it is really important. Please listen carefully. If you understand this knowledge very well, it is easy to understand the mechanism of diuretics. You have studied urinary production include glomerular filtration and reabsorption and secretions of ions and waters along the renal tubules and the collecting duct. Approximately 16 to 20% of blood plasma entering the kidneys is filtered from the glomerular capillaries. The kidney regulates the ionic composition and the volume of urine through the reabsorption and secretion of ions and water along renal tubules and collecting duct. Constituents except for protein and blood cells are filtrated when blood flows through the glomerulars. For a normal people, the volume of glomerular filtrate is about 180 liters in a day. 180 liters in 24 hours. But do you still remember? How much is the urine in 24 hours for the normal people? For a normal person? Yeah. It's just 1 to 2 liters in a day. So about 99% of glomerular ultrafiltrate is reabsorbed by the renal tubules. Some drugs, such as aminophylline and dopamine, acting on the glomerular, they just have virtually limited diuretic effect by increasing renal blood flow and glomerular filtration rate because of glomerular tubular balance mechanism. This drug, aminophylline, this drug is usually used to treat asthma. You don't study it now, but you have studied dopamine. Do you still remember this? By activation of dopamine receptor, it can dilate blood vessels, and by activation of beta-1 receptor, increase the cardiac work. Has positive effect on the heart, so they can increase renal blood flow and GFR. But dopamine cannot use as a diuretic, because this diuretic effect by dopamine is very weak. You have studied, actually, the more glomerular filtration, the more absorption from renal tubule. So this is glomerular tubular balance. So at present, most diuretics have diuretic effect by decreasing reabsorption of electrolytes and water from renal tubules. So in this chapter, you study many diuretics. They mainly act on the renal tubules at different segments of tubules. Actually, the renal tubules include different segments. They are divided into proximal convoluted tubule, Henle's loop, descending portion and ascending portion of Henle's loop, and distal tubule and collecting duct. The diuretics act at the different segment of the tubules. Now look at the function of proximal convoluted tubule. Here, it reabsorbed 60 to 65% of sodium ions and 60% of water. The mechanism of reabsorption in this segment is depending on hydrogen-sodium exchange and sodium-potassium ATPase. Now look at this figure. This means the epithelial cells of tubule, and this is the interstitial fluid, and this is the lumens of tubule. So the direction of reabsorption is from lumens to interstitial fluid through epithelial cells. So during this process of reabsorption in the proximal convoluted tubule, carbonic anhydrate, this enzyme plays a role in the reabsorption of the proximal tubule. Some drugs are inhibitors of carbonic anhydrase, like acetazolamide. It just produces weak diuretic effects. Because once here, reabsorption of proximal tubule is decreased, the reabsorption of the proximal tubule itself and the lower segment, like distal tubule, their reabsorption will have a compensatory regulation. So the inhibitors of carbonic anhydrase acting on the proximal convoluted tubule, just because of this compensatory reabsorption in the proximal tubule itself and the lower segment of tubules, it has very weak diuretic effects. Now, some drugs also act on the ascending thick limb of Henle's loop. Now look at this. This segment reabsorbed about 25 to 30% of sodium ions without absorption of water. Actually, this segment is impermeable to the water. This is the major site of high saline diuretics action. Now, this process of reabsorption depends on sodium potassium to chloride cotransporter, and in this membrane depends on sodium potassium ATPase. Now, both two enzymes during this process of reabsorption, potassium ions is converted into the epithelial cells, depending on sodium potassium chloride cotransporter and sodium potassium ATPase, then cause the accumulation of potassium ions in the cells. So these potassium ions diffuse back lumens to form a positive potential, and this positive potential falls magnesium and calcium ions to be reabsorbed through paracellular pathway to blood flow. So this is the reabsorption of magnesium and calcium ions. Actually, this reabsorption is depending on these two enzymes too. So this reabsorption process, it is affected if any of these ions is lacking. Now look at just now I mentioned. This ascending portion of Henle's loop, it is impermeable to water. It is just permeable to the ionic ions, So with the flowing of crude urine through these tubules, this segment with reabsorption of chloride, sodium chloride, osmotic pressure of crude urine, it is further decreased, because just this is permeable to the ions, but not water. So with the reabsorption, osmotic pressure is increase. So this is a process of diluting function of the kidney to urine. And sodium chloride in medullary interstitial space under the countercurrent multiple layer mechanism, together with urea, forms the medullary hypotonic area. This medullary interstitial space, osmotic pressure is relatively higher. And with the flowing of the crude urine in the tubule, and they reach to collecting duct. And this segment, at the collecting duct, plenty of water is reabsorbed under the regulation of ADH, anti-diuretic hormones. So with a lot of water reabsorption, osmotic pressure of urine in collecting duct can further increase. This is the condensing function of the kidney to urine. So here, I think you can understand. If some drugs inhibit the process of reabsorption acting on the ascending thick limb Henle's loop, they must affect the diluting function of the kidney and condensing function of the kidney to urine. High saline diuretics affect both diluting and the condensing function of the kidney to urine. So that's why they has the most potent diuretic effects. That's why they are called high saline diuretics. Okay, understand? This segment is distal convoluted tubule. This segment reabsorbed 12% of sodium chloride. The mechanism is depending on this sodium chloride cotransporter and sodium potassium ATPase. And this cotransporter is very sensitive to ceridide diuretics. But here, it just accounts 12% of reabsorption sodium chloride. So its action, diuretic effect, is relatively mild and actually lasting. Now, actually, this inhibitor of sodium chloride cotransporter inhibits the sodium chloride reabsorption, but without effect on the calcium reabsorption. Actually, calcium is reabsorbed by calcium channel in the luminal membrane and sodium-calcium exchange in the basolateral membrane under the modulation of parathyroid hormones. This is another mechanism of reabsorption of calcium ions. Actually, thyroid, they don't inhibit reabsorption of calcium, but actually they promote this process because this process is under regulation of PTH. So actually, effects on the reabsorption of calcium by thyroid is opposite to that of high-seling diuretics. Ending distal tubule and collecting duct. This segment reabsorbed 5% of sodium chloride, and the mechanism is depending on the sodium-hydrogen exchange and sodium-potassium exchange. This process depends in part on aldosterone. So some drugs maybe work as an aldosterone receptor antagonist. They can inhibit this reabsorption process. And some drugs maybe also just inhibit this exchange, also has a relatively weak diuretic effect, because here it just reabsorbed 5% of sodium chloride. Are you clear now? Different segment of tubules has different function for the reabsorption. So that's why the different drugs acting on the different segment of tubules, they have different diuretic effects. So do you know the classification of diuretics? Let's go on study. Look at this slide. It gives you a lot of information, not only about classification of drugs. It also shows you the agents in each group, their action size and mechanism. Now look at first. Loop or high-seling diuretics include furosemide, isocyanic acid, and bumetanide. They are inhibitors of sodium-potassium to chloride sympod, acting on the thick ascending limb of the Henle's loop. Thyroid and related agents. This group include chlorothyroid, hydrochlorothyroid, hydrofluomazidine, and clothalidin. They are moderate efficacy diuretics and inhibit the sodium chloride sympod, acting on the distal convoluted tubule. Potassium-sparing diuretics include spironolactone, triamcinolone, and amiloride. They are low-efficacy diuretics. Spironolactone is one antagonist for aldosterone, and these agents act on the late distal tubule and collecting duct by different mechanisms. Carbonic anhydrate inhibitors act on the proximal convoluted tubule. Acetazolamide is one low-efficacy diuretic. Now look at one by one in detail. Loop or high-seling diuretics. In this family, furosemide is the representative drug. Actually, these drugs, they have different chemical structure, but the site of their action, mechanism, and the side effects and clinical applications are almost analogous. Now first look at their pharmacokinetics. These agents can be administered orally or parenterally. Their action duration is relatively brief. If administered orally, diuretic effect lasts for 4 to 8 hours. If intravenous injection, it lasts for 2 to 3 hours. This drug acts on the thick ascending limb of the Henle's loop. Just now I introduced. This fragment is determines the diluting and condensing function of the kidney to urine. So, loop diuretics act here. They has the most potent diuretic effects. By inhibiting the sodium-potassium chloride cotransport carrier protein, so they can decrease the reabsorption of sodium, potassium, and chloride ions, decrease the luminal potential, then reduce the force of calcium and magnesium ions. So finally, excretion of calcium and magnesium increased too. So based on this based on this reaction, this drug has very rapid, powerful, and transient diuretic effects. With respect to all other diuretics, they exhibit the highest diuretic efficacy. Because of inhibition on the sodium-potassium to chloride cotransporter, this drug leads to the two results. The quantity of the sodium into the distal tubule and collecting duct increase, and the body volume is decreased, and the renal sympathetic nerve is activated. So this result facilitates the release of renin, and finally it can promote the secretion of aldosterone. So both two results lead to further enhance the exchange of potassium sodium ions in the distal tubule. So it can cause excessive excretion of potassium ions. So although it promotes the excretion of the sodium, including many other electrolytes and water, it especially promotes the excretion of potassium ions because of these two results. So when these drugs is used for a long time, because the large quantity of urine, including a great amount of water with sodium, chloride, potassium, calcium, and magnesium excreted. Finally, they can induce low blood volume, hyperkalemia, hyponatremia, hypochloremia, and hypomagnesia. So this is the final result. But usually, hypocalcemia doesn't occur because calcium can be reabsorbed actively in the distal tubule. So look at next pharmacological effect caused by loop or high-sealing diuretic is effect on renal hemodynamics. Because they dilate blood vessels before the onset of their diuretic effects, so they can increase renal blood flow and decrease the preload and decrease left ventricular filling pressure in congestive heart failure. So it has a significance to relieve pulmonary blood stasis. This is the effect on the hemodynamics of the kidney. It is useful in the treatment of pulmonary edema. Based on diuretic effect and effects on hemodynamics of loop diuretics, and especially because of their rapid onset of diuretic effects, particularly when given intravenously, These drugs are very useful in emergency situations, like acute pulmonary edema, brain edema, serious edema caused from heart failure or renal impairment, ascites of liver cirrhosis. You know, these edemas, either acute conditions or serious conditions, they all require immediately onset of diuretic effects. So these conditions usually we choose high saline diuretics first. And because they can promote excessive excretion of potassium ions, so in the treatment of hyperkalemia, it is very useful. It also used to treat renal failure because it can improve the blood flow to the kidney and then promote the urine protection and dilute the metabolic substance in the tissue, decrease the renal injury. And it also used to treat acute hypercalcemia because it can stimulate tubular calcium excretion. It also can be used to treat hypertension crises and used in the treatment of some intoxication by some substance. So work as the detoxicator. These are the therapeutic uses of loop diuretics. So because they have very rapid and powerful diuretic effects. So what are the adverse effects of loop diuretics? Can you guys? Welcome back. Let's go on study adverse effects of loop diuretics. Because these drugs have very rapid and potent diuretic effects, especially promote electrolysis excretion. So they first induce turbulence of water and electrolytes when they used too much or for a relatively longer time. Because of excessive diuresis, they may induce low blood volume, hypokalemia, hyponatremia, hypochloremia, and hypomagnesemia. Especially more often induce hypokalemia. So it is necessary to supplement potassium salt or combination with potassium-sparing diuretics. I should tell you, if hypokalemia and hypomagnesemia are present at the same time, hypomagnesemia should be corrected first. Otherwise, the hypokalemia is not easy to be corrected because the activation of sodium potassium ATPase needs magnesium ions. So, first corrected this. Okay. Next, autotoxicity. If someone is suffering from autotoxicity caused by loop diuretics, the symptoms may be vertigo, tinnitus, hearing impairment, even transient or permanent deafness. And this toxic effect is dose-related, and it is more often occur on aceclinic acid or renal insufficiency or on administering other autotoxic drugs simultaneously, like, for example, aminoglycosides, like streptomycin, do you know? Maybe you know gentamicin. These are aminoglycosides. You will study these antibiotics. This drug also has autotoxicity. When they used simultaneously, this toxic result will show more often. The mechanism of this ototoxicity by high-seling diuretics is also related to inhibition of sodium-potassium to chloride cotransporter. So they can decrease the secretion of potassium chloride into the endolymph, impairing the higher cells on cochlear basal membrane. And compared with the other agents, bumetanide has the least ototoxicity. So it should be used for the treatment of acute renal failure with a hearing defect. Next one, hyperuricemia. But GOUT is rarely caused because after diuresis, blood volume and volume of extracellular fluid and glomerular rate is decreased by the high-seling diuretics. So they can increase the reabsorption of uric acid in the proximal convoluted pupil. And the next reason is diuretics of these drugs and the uric acid compete during their elimination through organic acid secreting pathway. So they have a competition during excretion. So increase this uric acid in the plasma to cause this hyperuricemia. Although they don't induce GOUT, but for the patients with GOUT, it also is necessary to pay more attention. High-seling diuretics also increase LDL and decrease HDL, and also induce hyperglycemia and allergic reactions, even leukopenia and thrombocytopenia, GI tract reactions. So there are 4 points for the adverse effects of high-seling diuretics. Okay. Are you clear? Turbulence of water and electrolysis, ototoxicity, hyperuricemia, and others, hyperglycemia, and allergic reactions, even GI tract reactions. Okay. Now, you finished the studies of high-seling diuretics. What are the pharmacological effects and therapeutic uses, adverse effects of thiazides? Good. Welcome back. Let's go on. Thiazide and related agents. This group includes several different agents. Compared with high-seling diuretics, they are the most widely used diuretics because their effects are relatively mild and lasting. You know, loop diuretics, their diuretic effects is very rapid and very powerful but transient. So usually they are used to some emergency situations. Now look at the pharmacological effects of thiazide. Included 3 points. In Chinese, just 7 words. 利尿, 降压, 抗利尿. Now look at in English. Diuretic effects and lower blood pressure, or depressor effects, and effects against diabetes insipidus, including nephrogenic and pituitary diabetes insipidus. Okay, study one by one. Diuretic effects. Just now I mentioned. Diuretic effects by thiazide. It is gentle and lasting. So they are called by moderate diuretics. They act mainly on the distal tubule, especially the initial segment of distal convoluted tubule, by inhibition the sodium chloride cotransporter and decrease the reabsorption of sodium and chloride ions, increase the concentration of sodium ions at the distal tubule, facilitating sodium-potassium ions exchange. So the final result is to increase the excretion of sodium ions and potassium ions, especially potassium ions. Long-term uses of thiazide may result in loss of potassium ions from body. So it is necessary to supplement potassium salt or to be used in combination with potassium-sparing diuretics. But actually act on the calcium excretion. It has a different result from loop diuretics because they can decrease urinary calcium excretion. The mechanism is this. Because thiazide promotes the reabsorption of calcium by facilitating sodium-calcium exchange at the distal tubule. This process is modulated by PTH, parathyroid gland hormones, parathyroid hormones. Thiazide promotes this process of reabsorption of calcium ions. So these drugs can decrease the concentration of calcium in the urine. This is contrary to loop diuretics. Loop diuretics, they promote the calcium excretion. So increase the calcium concentration of the calcium concentration in the urine, promote the excretion of calcium. Thiazide also lower blood pressure. This is the result from diuretic effects on the excretion of sodium ions. Actually, when these drugs used for relatively longer time for the patients with hypertension, its diuretic effects is not very obvious, but they still can decrease the blood pressure because they decrease the concentration of calcium in the endothelial cell of blood vessels. So finally, because of the sodium-calcium exchange, this also can be decreased. The final result is concentration of calcium ions in the endothelial cells. It can be reduced by thiazide. So for the muscle cells, they induce vasodilation. So they work as the basic hypotensors. For the details, see the chapter 25, hypertensive drugs. In that chapter, you will study many antihypertensive drugs, including diuretics. Here, it mainly means thiazide work as antihypertensive drugs. Thiazides also have effects against the diabetes insipidus, including nephrogenic and pituitary diabetes. Actually, these mechanisms of thiazide in this disease treatment, it is still unclear, but they are really effective to control nephrogenic and pituitary diabetes insipidus. Maybe you are not very clear about these two diseases. Diabetes insipidus, the patients usually are very thirsty and drink a lot of water, so they often have polyuria. If it is nephrogenic pituitary diabetes, usually it is results from defective or absent antidiuretic hormone receptor or absent acroporin at the cortical collecting duct. in most cases due to drug-induced nephrotoxicity. It is characterized by unresponsiveness to the antidiuretic hormone action. If the patient has pituitary diabetes insipidus, the disease is in the pituitary glands. Pituitary diabetes insipidus arises primarily from the deficiency in antidiuretic hormone secretion by the pituitary glands. So this hormone secretion is not enough. In both nephrogenic and pituitary diabetes insipidus, there is wrong in the process of aquaporin-mediated water uptake from collecting duct, which lead to polyuria. So when the patients use Diuretics, these drugs can decrease the thirsty sensation for the patients. So decrease the water intake. It is useful to improve the symptoms of the patients with diabetes insipidus. So here, based on the pharmacological effect of Diuretics, mild and lasting diuretic effects, lower blood pressure, and effects on the diabetes insipidus. So I think you can guess what are their therapeutic uses. First one, used to treat hypertension. Because this drug causes lower peripheral resistance without having a major diuretic effect. Just now I explained. If they are used for a relatively long time, its diuretic effects usually it is not very obvious, but they still reduce blood pressure, decrease blood pressure. So in the treatment of hypertension, they usually work as one of basic antihypertensive drugs. Yeah, you will study this in detail when you study antihypertensive drugs. Because of diuretic effects, this drug also used to treat cardiogenic edema, caused by heart failure, chronic heart failure. The patients with heart failure, they usually have edema because of mild and lasting diuretic effects by Diuretics. To improve this edema is really helpful, but only used to treat mild to moderate congestive heart failure. If the heart failure is very serious, even Diuretics fails to treat this congestive heart failure, you had better choose loop diuretics. This drug Diuretics also used to treat nephrolysis. This is caused by higher concentration of calcium in the urine. It also named idiopathic hypercalciuria. There are higher concentration of calcium ions in the urine. So try to decrease the calcium excretion with the urine. It can improve this disease. And used to treat osteoporosis, try to increase the calcium concentration in the blood. These drugs are very effective by inhibition of urinary calcium excretion. In the treatment of diabetes insipidus, because of unique ability to produce a hyperosmolar urine, it is very useful. These drugs, their pharmacokinetics, they are secreted and eliminated mainly from the proximal convoluted tubule in original form and are removed out of the body in 3 to 6 hours. Actually, this elimination process in the proximal convoluted tubule is similar to that of loop diuretics. All in the proximal tubule. Proximal tubule, it is the site of the organic acid and basic secretory symptom. The organic acid secretory symptom, it is saturable, and diuretic drugs, including thiazides and loop diuretics, in the bloodstream compete to transfer with endogenous organic acids, such as uric acid. So here, I think you can understand the adverse effects of thiazides, also including hyperuricemia. Now look at the adverse effects caused by thiazide. They are diuretics. So first, side reactions, also similar to loop diuretics. It is electrolyte disturbances, including hypokalemia, hyponatremia, hypocalcemia, hypomagnesemia, volume depletion. Especially hypokalemia. This potassium depletion, it is the most frequent problem. So it is necessary to use this drug in combination with potassium-sparing diuretics when they are used for a long time. Or sometimes it also is necessary supplement potassium salts, try to avoid hypokalemia. And hypocalcemia, loop diuretics has relatively less effect on the calcium excretion. But this one, it can promote reabsorption of calcium ions and the regulation of PTH. So maybe it can induce hypercalcemia. Try to avoid this. Sometimes it also can induce volume depletion, cause orthostatic hypotension or lightheadedness, even hypochloremia, alkalosis. Yeah, just now I mentioned. They also induce hyperuricemia because of competing for transfer with endogenous organic acid in the proximal tubule because of this competitive mechanism. So they delay the uric acid excretion. So that's why the patients with gout should be cautious for using these thiazides and related agents. This drug, they also induce metabolic changes. Maybe they lead to hyperglycemia and lipidemia. Now, because they can decrease glucose tolerance and increase blood glucose. It may be related to inhibiting insulin secretion or enhancing glycogenolysis and glyconeogenesis. So for the patients, they also increase the serum cholesterol and increase the triglyceride and LDL and decrease the HDL, induce hyperlipidemia. So I think you can understand for the patients with hypoglycemia, or hyperlipidemia should be cautious for using these drugs. These drugs also induce gastrointestinal symptoms and allergic reactions such as hemolytic anemia, thrombocytopenia, acute pancreatitis, photosensitive dermatitis, and biliary obstructive jaundice. So this also much similar to that of loop diuretics, but cyanides, they don't induce ototoxicity. It is different from cyanides, loop diuretics. Okay. Clozalidin. This drug, actually, it is not one of cyanide, but its diuretic effects is analogous to that of cyanide, just with longer action. Its diuretic effects can last for 1, even 3 days. Adverse effects include nausea, vomiting, weakness, headache, fetal deformity, fetal deformity, or fetal death. Okay, just now you've finished the studies of cyanides. Actually, they are more common used in the treatment of some chronic disease. So what are the characteristics of potassium-sparing diuretics and carbonic anhydrase inhibitors? Go to study next section. Thank you.